REMAC to order. Marie, you want to start with the roll call?
Yes, sir. Okay, please answer when I call your name. Robert Winchell. Joseph Schenker. Michael Batch. Robert Ackerman.
Present.
Nicholas Alexandru.
I'm here.
Christopher Graciano.
Present.
Eric Cohen. Mimi Langsam. Kevin Mujal.
Present.
Cindy Basilos. Dario Gonzalez.
Here.
Glenn Aceda. Bradley Kaufman. Doug Isaacs.
Here.
Nathan Reisman.
Here.
Selena Lloyd. Allison Burke. Jeffrey Rabbit.
Here.
Heidi Cordy. Louis Marshall.
Here.
Michael Redlener.
Present.
Michael Gutenberg.
Present.
Pamela Lai.
Here.
Dominic Battinelli.
Here.
Scott Chang.
Here.
Peter Wire.
Here.
Paul Barbara.
Here.
David Benelli.
Right to your left.
Celia Quinn. Timothy Stiles. Welcome to the committee, Dr. Stiles. Charles Martinez.
Present.
Joseph Bove.
Present.
Martin Grillo. Matthew Harris. Stephen Blumberg. William Fisher.
Here.
Robert Krupe.
Here.
Jessica Van Voorhees. Arthur Cooper.
Here.
Yeah. Yadidja Langsam. Anthony Shalish.
Here.
And Christopher Sorrentino. Give me a second to see if we have a quorum.
Okay.
Yes, we have a quorum. We have-
All right.
everybody's actually
We need
signed in
approval of the minutes from November 15th, 2016. They're emails. Have a motion? We have a motion second. Dr. Martinez, okay. All in favor? Any opposed? Okay, minutes are approved. Correspondence report.
now. Okay. For membership, there is no new information. Enforcements from the Department of Health, we have one person from Brooklyn, Ali Fatah, an EMT. He had a $1,000 civil penalty for violations of 816 and 803. And someone from Canastota County, Kenneth Balea, with a $2,000 civil penalty. Neither of them had their certification revoked. We received a copy of a letter sent to Staten Island University Hospital South Campus from the Department of Health stating it has been designated a stroke center. There's a change in the FE auto injector law where before the regional council would have to receive applications from agencies and camps and different places to be allowed to use it. Now anyone that gets a script from a physician is allowed to use the FE. Also, 800.5 requirements for ALS systems. In New York City, it's not really a problem, but for the rest of the state, they're now required. If you're ALS, you must carry narcotics, and you have to have a controlled substance plan that's a Part 80 application. We sent out agendas, minutes, and associated attachments for this meeting, and a letter was sent to the American Heart Association and the American Stroke Association supporting its application to receive funding. And that's all we have for correspondence this month.
Thank you. Committee reports, medical standards. Dr. Ballard.
Yes. So medical standards met just prior to this meeting, and we reviewed many protocols, many protocol changes that were all voted and brought to REMAC for REMAC's approval. Before we go over the protocols, there were two other two other items that we discussed. The first one was to bring forward as a recommendation to REMAC to bring to the QA/QI committee for further review reports that by some hospitals that the dosing of Versed in the delirium protocol, in the excited delirium protocol, might be too high for pediatric patients. That was the first item that was brought for further discussion to REMAC. The second item was a suggestion to create a tag to further evaluate how to proceed with medical oversight during mass gathering events.
You want to do the protocols first and then come back to that, or?
Up to you. You're the boss.
Why don't we do that, and then we'll come back to these?
Okay, I just a moment.
Yeah. I wrote it down.
So the protocols, many of you have been here. We discussed, we discussed some GOP changes as opposed to mass gathering events. We talked about medical control at the scene by physicians who non-solicited medical intervention. And that was voted by medical standards to go back to protocol for further review, because protocol is working on revising this whole section in the GOP to make it more comprehensive and easier to follow and understand by everyone.
So that's informational only, right?
That is correct.
That's going back to protocol.
We then discussed in the GOP and in protocols 557, I think that's it. We talked about using the doses on length-based dosing devices may only be used for the specific indication listed on that device. The reason that came up was that in pediatric seizure protocols, when using the Breslau tape, which we currently have, some providers were using the induction dose of Versed to treat seizures, which was not the appropriate dose. So we corrected, we added a section in the GOP stating that when you use the,
Does anybody need this on the screen, or did you bring your copies with you?
Yeah. Can we put it up there?
I'm sorry, can you put that back on the screen, the same thing we had up before, the summary?
Just for reference, in case somebody hasn't seen it.
So we discussed that when we do use the length-based dosing device in the GOP, then it can only be used for the indication that is specified on that device. And we also updated protocol 557 pediatric seizure. We changed the hypoglycemia threshold from 120 to 60, so treat anything below 60. And the doses and added a comment that the doses on the length-based dosing device may only be used for the specific indication listed on the device. And we also updated the dosing of Versed and Valium? Diazepam and lorazepam, sorry, diazepam and lorazepam in that protocol. So that was the
So that
first
comes
one.
forward as
That comes
second
forward as
motion.
second
I
motion.
thought I was losing my eyesight.
So the motion is to change the length-based dosing device only for the specific indications, change the glucose level, and the lorazepam dosing, and
And
the
diazepam.
diazepam dose.
Yes,
Okay.
so that's both in the GOP and protocol 557.
And everyone, this was emailed to everyone, so if you have any questions, you'll have it.
Any discussion on this? Seeing none, all those in favor? We have to do a roll call, right? It's protocol or no?
Do all of them together.
Or
Want to do them all
we'll do them all?
together?
All together.
All right, we'll do them all together.
Yeah,
since
unless
it is
someone
a
has a
lot
real
discussion.
objection to a
Yeah.
protocol.
If someone wants something pulled out, discussed separately, let me know. Otherwise, we'll do them all together and do one roll call.
Perfect, almost.
New chair.
Next item.
Next item is applying to the GOP again and to protocols 500A, 500B, 504B, and 510. It talks about adding, it talks about vasopressor infusions, adding vasopressin as an option on top of dopamine, and stating that any administration of a vasopressor, both norepi and dopamine, you must use a
Flow metering device.
flow meter device, right, Doug? That was
Is
the,
that the- Flow metering device?
flow metering device, to,
Regulate, flow regulating device.
flow regulating device in order to administer those medications.
Okay, good.
Next. Protocols 303, 403, and 503, VFib plus process VTAC. We voted to change that protocol to say that CPR should be initiated immediately until the defibrillator pads are attached. We removed the definition that discusses witnessed and unwitnessed cardiac arrest. As it has been, there has been differentiation in the past that has not been proven to have any benefit either way. Next. Protocols 411 and 413. We discussed adding glucometry if available, and treating for readings below 60, treating hypoglycemia for readings below 60. We said that in the future this will also apply to 412 stroke. And I think that's it, right? 500A, 500B, 510 we talked about. 511, altered mental status, there has been some wordsmithing over there, and in addition to that, we also changed section, so the wordsmithing was in section 5, suggestion that was brought forward by the New York City Poison Control Center. If an overdose is strongly suspected and the patient's respiratory rate is less than 10, administer Narcan, titrate at 0.5 milligrams up to response up to 4 milligrams, IV, IO, IN, or IM. That was the first part of it. The second part was in patients with diabetic, section 4, that's the section above it. It was written, this was brought by Medic Basic. They noticed this little, I guess, neglect to remove from the past. Currently states in patients with diabetic histories where IV saline lock is not available, administer glucagon, IM or IN, and the comment was, even if they don't have a diabetic history, we still should give hypoglycemic patients glucagon, IM or IN, since we can measure and establish that they are hypoglycemic. All ALS units carry glucometers. That was 511. Protocol 528, there were two, that's the burn protocol. There were two additions over there. There was correction of the wording of the note. The note currently states that the administration of narcotic analgesics is contraindicated in patients with burns involving the face and or airway, and we felt that that's a little too strong wording because it is not contraindicated. It should be administered in caution. Therefore, the wording has been changed to, for patients with burns involving the face and or airway, consultation with online medical control is required prior to administration of analgesics. In addition to that, we added a section that discussed the need to give patients with burns IV fluids to begin fluid resuscitation in the field. So for adults, it's a rapid infusion of saline or ringers, up to 1 liter, and for pediatric patients, it's the same fluids, up to 20 mLs per kilogram with a max of 1 liter. And there's a note over there that accurate documentation of periodic fluid administration is required. That's highlighted, of course, because we use that as part of the calculation in the Parkland formula, and the fluid resuscitation for burns. Protocol 530, excited delirium. We added the size, the gauge of the IV to be 14 to 20.
Yes.
And we also added a finger stick to obtain, once the patient is calmer and you can obtain vital signs, also to get a finger stick because we don't want to miss hypoglycemia cases in these patients who are agitated.
We should go to their meeting.
Protocol 550, pediatric respiratory arrest. We revised the Narcan dose en route to match 556. It talks about that if we don't have IV access, then we should give Narcan through IN or IM. Protocol 556. I'm getting there. 556, we talked about the administration of Narcan in patients less than 2 years and above 2 years. less than 2 years is up to 1 milligrams of Narcan, and above 2 years and above is 2 milligrams of Narcan. And that's it. So
Let's do the protocols. and we'll
that's
go
the
back to
protocol,
it,
then
yeah.
we'll go back there.
Is there any protocol changes someone wants to discuss? Seeing no discussion, the vote will be on all the red protocol changes. We'll have a roll call vote.
Okay, just answer yes, no, or abstain when I call your name. Robert Winchell, Joseph Schenker, Nicholas Alexandru,
Yes.
Christopher Graciano,
Yes.
Kevin Munjal,
Yes.
Cindy Basilos, Dario Gonzalez,
Yes.
Glennis Seda, Bradley Kaufman, Doug Isaacs,
Yes.
Nathan Reesman,
Yes.
Jeffrey Rappert,
Yes.
Heidi Cordy, Louis Marshall,
Yes.
Michael Redlener,
Yay.
Michael Gutenberg,
Yes.
Pamela Lai,
Yes.
Peter Wire, Paul Barber,
Yes.
David Benelli,
Yes.
Timothy, I'm sorry, I can't remember your last name, Stiles? Timothy Stiles.
Was that yes to your name or yes to?
Thank you.
Call the question.
Charles Martinez,
Yes.
Joseph Bowe,
Yes.
Matthew Harris, William Fisher,
Yes.
Robert Krupe,
Yes.
Jessica Van Voorhees, Arthur Cooper.
Yes.
That's all our voting positions.
All right, so the vote is unanimous. Protocols pass. Do you want to do the sunset date next?
Yes, let's do the sunset date.
Very good.
So, the next item that came forward from Medical Standards was a recommendation for a sunset date of December 31st of 2017 for glucometers to be on all BLS ambulances. Discussion. All in favor?
It's,
So we don't, we don't,
We don't
this
gotta do
doesn't
the
require
whole-
roll call.
No.
No. All in favor?
Yep.
Any opposed? Abstentions? Okay, passes. Any other business from,
there was 2 others.
you want to go to the QA excited delirium maps?
Yes.
So there was was this a motion?
A motion from,
It was a recommendation, so I guess we have to make a motion here, that the QI committee be tasked with querying the hospitals on the excited delirium protocol, particularly with attention to pediatric dosing. Is there a motion to that effect?
doesn't the
Do we
Council
need a
of
motion?
Medical Standards have a motion and then you need a second?
Yeah, so it's, right, so we need a second.
I second.
Okay. Discussion on this, referring to, okay. All in favor? Any opposed? Abstentions? All right, QA is tasked with that. Thank you. The next was a recommendation from the Medical Standards Committee that the REMAC establish a tag to look at mass gathering events, to investigate the regulations around them and what, if any, this body's role would be in recommending standards for such. Are you willing to chair that tag? Okay. Anyone else interested in participating? I guess they can let you know, right, Marie?
Yes.
Yeah, anyone who's interested, let Marie know if you're interested in participating on that tag. Thank you. Any other?
Nope.
Okay.
That concludes the report of Medical Standards.
The only other thing for medical standards, one announcement is that interested parties who have specific interest in protocol changes or amendments or others should try to attend the protocol meeting, which is, when is the protocol meeting? It's the Friday, usually the first Friday, right? Or 2 weeks before.
Next one is March 3rd at noon.
There you go, March 3rd at noon.
Please let me know ahead of time because it's a small room. And if we get too crowded, we may have to.
Well, yeah, if enough people come, they'll get a bigger room in there.
I'd like to know before.
They're very
we get there.
hospitable out there.
Yeah.
All right, thank you. That concludes your report? All right,
Sorry,
thank you.
What was that last thing that was going on after the Dazzling? Was it the mass
That'll be
gathering?
tagged, the mass
The
gathering.
mass gathering tag,
Sorry.
yeah.
Jim, please come forward.
Yes, please come. Regional Council update.
I have a report here somewhere, just give me a
Okay.
second.
Was that? Yeah, okay.
While you're looking, I'm going to reverse things. I'm going to ask Dr. Marshall to give the CMAC report first. Can we do that?
Sure.
Just to keep, in the interest of keeping things moving?
Yes, absolutely. So, CMAC met in January, CMAC and SIMSCO, and there were a couple things that came out of that meeting. One was that CMAC and SIMSCO both issue advisories and guidance documents and policies, and the state said that if those recommendations are not in the regulations, then they are not enforceable. So when we talk about issuing advisories and policy guidelines, and we're going to require something, then we have to make sure that it's in Part 800 in the regulations. Or it will be very difficult to enforce it with our agencies. There was some discussion on the certificate of need process, and the regions really have to decide what need is in terms of looking at CON applications in the region. And in 2016, there was a large increase in the number of CONs. I don't know because there were more licenses available, but there were 50 CONs in the state that they had. Marie mentioned the check and inject program, not the epi auto injector program. Check and inject program was a program that was started by University of Rochester, which they put together a kit which contained 2 syringes, which had 1 mark on it. One syringe was for pediatrics, and it had a pediatric mark on it, and the other one was for adult, along with a vial of epinephrine. And that was, the cost of that kit was about $70 as compared to $700 for an auto injector. So this was originally a pilot project within the state. Involved, it worked out very well. I can't tell you the numbers off the top of my head, but the Commissioner of Health signed it recently, so now it is available to all agencies in the state to obtain these check and inject kits. I don't know, we'll have to get the information about where you can order them from. The University of Rochester was doing it initially, but they will no longer be spearheading it since this is a statewide option at this point. So that's something that we'll have to get you information on. New York City protocols were approved with some minor changes. There were a lot of discussion. The fire department brought forward a demonstration project, which we discussed here in terms of CFRs administering epi, aspirin, and albuterol. And after a lot of heated discussion, it was determined that they didn't need approval or a project to use epi or aspirin. And so they only needed it for albuterol. But that was approved by CMAC, but then when it got to SIMSCO, it was not approved. So that project for CFRs to administer albuterol was not approved at the SIMSCO level. And if you're interested in, watching a webcast.
We'll get you the time on the video where you can start.
Yes. Very interesting. We also had a lot of discussion on critical care level, and a lot of that doesn't apply to New York City because we got rid of the CC level some time ago, but a lot of regions in the state, including Long Island, rely heavily on CCs. But we have a tag with Medical Standards Committee, which is looking at eliminating the CC level of provider in the state and coming up with some sort of bridge project to, like we did in New York City, we bridged them to paramedic. And so we're going to come up with a similar project for New York State for the areas to be able to upgrade their CCs to paramedic, or they could use the AEMT level, which is now, because we want, New York wants to follow the national guidelines. New York State right now is the last state that has CC level providers in the country. So there's issues there with portability of certification and going from one state to another and things of that nature that we want to eliminate. So that's something that will be coming forward. What else? EMS Memorial is May 23rd. May 1st is the deadline for award submissions to New York State for EMS awards, so please start thinking about who to nominate. And Vital Signs is coming up in October in Rochester. And we also are going to be reviewing the statewide BLS protocol, so if anybody's interested in working on that at the state level, let me know and we'll get you involved in reviewing the BLS protocols for the state, because they haven't been looked at in a gazillion years, at least a decade. So,
All right. And the next CMAC meeting is May 9th, is that?
May 9th and 10th. That's my report.
Thank you.
It's been a vestige since this.
Regional Council update.
Regional Council last met January 31st. Dr. Marshall was reappointed as a representative to CMAC.
Thank you. Congratulations.
Condolences, congratulations. The council also will nominate Yadidra Langston, Robert Coopy, and Mitchell Powell to SEMSCO. SEMSCO now wants more than one nomination. Though Dr. Langston will be in that seat at least until June. We had no applications for determination of need, wonderful. No transfer of operating authority applications. Once again, the fire department CFR demo project was approved by our regional council, though it wasn't approved by the state council. Okay, check and inject program at the time of this meeting was still in force, and the agencies that participated in the study can continue to continue in the program. The law has been signed. I need to speak to Lee Burns to find out how we can get information to our agencies here on how to use the new type of EPI. REMSCO is waiting for delivery of additional naloxone. We have agencies who we've given the naloxone to through funding from a grant. Some of the naloxone has expired, so we put in another request to get more naloxone. And we did it at least a few weeks ago. I don't believe we've gotten it in yet. As soon as it comes in, we'll be communicating with squads and.
Just one quick question on that. There's been talk about using another naloxone
The spray bottle
dispensing
thing?
device.
Yeah.
But the problem there is that it delivers 4 milligrams in one shot. And I don't know where we're gonna go with that, but it's gonna have implications on the pediatric dosing, just to.
I've
Is
seen
that available yet? I don't know if that's available yet.
It's been talked about. I
Yeah.
know that they've been having trouble, getting the whole kits.
Yeah.
So, that's just something else to consider,
I saw a picture of it.
Yeah.
That's
it's
about
like
it.
a little,
Yeah. I'm not sure it's got final approval yet. Yeah,
but it delivers 4
It's like a
milligrams.
nasal spray. You just,
but it's 4 milligrams.
4 milligrams in one deployment.
Talk about shooting your load.
Yeah.
Madeline, I'm just.
And I don't think they've made any compensation for kids.
Other regional council.
Okay.
Let's move on.
Yes.
Well, SEMSCO, okay, it was stated at the January 2017 SEMSCO meeting. Dr. Marshall already mentioned this. If an item is not in public health law, it's not enforceable. So that doesn't, however, change the fact that REMACs can require AEDs and epinephrine and albuterol and all those other things. So, the CIC and CLI instructor exams, I don't know, for those of you that are in EMS education, we have like a really high failure rate. What's really sad is that most of our senior instructors are really not doing well on these exams. So here in this region, we're getting a small group of regional faculty and CICs to put together a prep course to try and help our instructors. We also spoke about the Greater New York Fire Department MCI program. It was presented here at the last meeting. We had a conference call in between meetings, and we'll be bringing forward more information to this committee. Our next meeting is February 28th.
Excellent. Any questions about the regional council? Michael, I realize I skipped you. QA report. Do you have anything to report from QA today?
Just a few minor things. There's no new co-sponsors We had a membership change. Dr. Lai will be